Hello, I am David Thompson, a partner in BLM's catastrophic injury team and member of the amputation subject matter group. I'm joined today by Professor Robert Greimer to talk about osseointegration for amputees. Professor Greimer is an orthopedic surgeon who's been doing medico-legal reports since 1982. He has extensive experience of amputations at all levels. He was the principal investigator for a clinical trial of osseointegration called the ITAP study, and he regularly provides reports on amputation cases. By way of background, osseointegration involves implanting a titanium anchor rod directly to the bone of an amputated limb, which extends out of the residual limb to which a prosthesis can then be attached. It is an alternative to traditional socket methods of prosthetic attachment. So, Professor Greimer, please could you tell us about the pros and cons of osseointegration?
Yeah, well, good morning and thank you, David. The pros of osseointegration are that it abolishes the problems that many patients have with socket fitting on the amputation stump. And this is surprisingly common. About 30 to 40% of people with an amputation, particularly an above knee amputation, will have socket fitting problems. Either it will be uncomfortable, it will be sweaty, they can't wear it all day, or the stump is too short for them to get a good lever on when working the leg. And if you can get a successful osseointegration, they really do feel the benefits in that they can put their artificial limb on in the morning. It fits on a bit like a hose lock onto your peg at the tap. They click it on and they're off, and they can then use it all day. They get better proprioception of where their artificial limb is in space. They can actually feel when it touches the ground and much more sensation, and it abolishes the stump problems. So if it works, it's brilliant. What are the downsides? Well, the trouble is it is still an unproven technology. It is not accepted by NICE for use in the UK at the moment. It's not available on the NHS. It is available privately. And a lot of other countries are still not funding it through their health services. And the reason for this is that it's quite expensive, and there's a high rate of complications still. And the complications include infection, and loosening, and possibly maybe 10% of people will need to have it removed, and they then need an amputation at a higher level, which can be disastrous.
Who do you think would most benefit from osseointegration?
Well, it's going to benefit the people who are high activity users, who are otherwise fit and healthy, who have problems with getting their artificial leg to be comfortable on their stump. Double amputees, usually people who've been involved in serious accidents or the military, are particularly likely to benefit. But single amputees who have socket problems are the main ones. Of course, there are some contraindications to doing this procedure, and this includes people with infection, with very short bone or deformed bone remnants, people who are on steroids, who have osteoporosis, or any psychiatric problems. And also smoking is a relative contraindication.
What are the costs involved?
Yeah, well, because it's only available on the private sector, we don't really know. But recently, a case I was involved in, the patient had a quote for £80,000 for the surgery and fitting of the implant. But then there's the additional costs of getting a fail-safe device to fit on, so that if they fall, the artificial leg falls off and it doesn't break their bone. But I understand that the artificial limb costs going forward into the future are probably pretty similar to what the cost of an artificial leg would be for an ordinary patient.
And what about the risks?
Well, the risks, as I mentioned, are infection, and the problem is that no one around the world has completely solved the problem of preventing infection getting in around where the peg comes out through the skin. And that frequently gets infected in many patients. In many series, 80–90% of patients will need antibiotics at one time or another. And in many cases, 20 to 30% of people could be on long-term antibiotics. And in a percentage, that will lead on to deep infection, osteomyelitis, and the need for amputation. So that's the main peril. And the trouble is that the long-term results of this have not been published yet. So it is still a relatively young technique.
What further developments might we see in the next 3 to 5 years?
Yeah, well, there is increasing experience around the world of this, and I think it is likely that there will be improvements in getting the skin to bond to the metal implant and prevent infection getting in. But the place where I see the biggest and most exciting changes is going to be in the upper limb, because current prostheses for above elbow amputees, so that's mid-humerus amputees, are very bulky, they're very awkward, and they don't work very well. And if you have a good osseointegrated peg sticking out of your humerus, you can click on your artificial arm to that. And then there's quite a lot of sophisticated work being done on re-innovating muscles, sometimes using targeted muscle re-innovation, to get those muscles to perform activities that you'd normally get your hand to do. And those sensations in the muscle can then be transformed to a myoelectric arm. And there are some very, very impressive results of myoelectric arms combining osseointegration and TMR.
Thank you, Professor Grimer. That was a fascinating insight into an important topic for insurers and our other clients on an issue of growing importance in amputation claims. Thank you for joining me.
It's been an absolute pleasure.